Welcome to Stride to Success, St. Luke's preparatory class for knee and hip replacement patients. My name is Ann Callan. I'm a staff nurse on the orthopedic division here at the hospital. Kelly Butler is our head nurse. During this video, you will hear a description of what to expect from physical therapy and occupational therapy services while you are in the hospital. Next, there will be an explanation of the role of the care manager in your discharge plan. Then finally, there will be a thorough overview of your hospital stay from admission to discharge. We hope this video helps you gain knowledge of your upcoming surgery. It is our hope that this information will alleviate fear of the unknown and will better prepare you in your recovery after your knee or hip replacement surgery. Physical therapy will begin the day of your surgery. Recent studies have shown the quicker you are up and moving after surgery reduces the chances of complications occurring in your recovery. The therapist will ask questions about your home setup to evaluate the areas that need to be addressed in your therapy sessions in order to go home safely. They will want to know about steps in the home, from entry steps to bedroom steps or basement steps. Your bathroom setup will be discussed to determine your safety needs in the bathroom. Once this evaluation is complete, the therapist will have you do exercises in the bed. After this, the therapist will have you sit up on the side of the bed. Then the goal is to have you stand and possibly do some walking in your room, and then you will sit up in the chair for approximately an hour. The next day, physical therapy will see you twice a day, once in the morning and once in the afternoon. Each time you will complete bed exercises and add more activity with each session. You will progress to our satellite gym on the orthopedic division where you will practice going up and down stairs. Before leaving the hospital, you will watch a car transfer video to assist you in getting in and out of your vehicle. The therapist will give you several tips on your initial recovery at home. One suggestion is to have a sturdy armchair without wheels available to sit in, as this will make getting up and down easier. Sitting in a recliner or a sofa will make getting up and down a challenge. The therapist will make recommendations on any equipment you need in your bathroom to assist you. If you have any questions concerning getting around safely at home, please feel free to ask your therapist, as they are an excellent resource to address these issues. The therapist will check to see if you have a walker to use when you arrive home. If you already have a walker at home that was fitted for you, it is not necessary to bring it to the hospital, as you will use all of the hospital's equipment. If, however, you have a borrowed walker from family or friends, please have someone bring it in so the therapist can evaluate it for structural stability and make sure it is adjusted to your height. We have an equipment provider here at the hospital, so any equipment you need upon discharge can be delivered directly to your room. It is not recommended to purchase equipment beforehand, as you will not know what you need until after your surgery. If you are able to borrow equipment, that is highly recommended. We will now discuss what to expect from occupational therapy. Occupational therapy focuses on the activities of daily living, like bathing, dressing, meal prep, pet care, etc. The occupational therapist will recommend any adaptive equipment to help you be more independent at home. Occupational therapy will see you once a day. Not all surgeons order occupational therapy for their patients, but you may certainly request the service if it is not ordered. Home safety is addressed by the occupational therapist as well. They are an excellent resource to help troubleshoot any safety issues in your home. Safety issues, of course, can be addressed by physical therapy as well. We will now discuss the role of the care manager or transition coordinator in your discharge plan. The goal is to get you home, as you are more comfortable in your own home and there is less chance of infection happening there. We will now discuss the role of the care manager or transition coordinator in your discharge plan. The goal is to get you home, as you are more comfortable in your own home and there is less chance of infection occurring at home. The care manager will come into your room the day after surgery to discuss your discharge plan. The primary goal is to have you leave the hospital and go to outpatient physical therapy within 48 hours after arriving home. The patients that go to outpatient physical therapy seem to get better faster, as the outpatient facilities have excellent equipment to assist you in your recovery. You typically choose an outpatient facility close to home for convenience, as you will be attending outpatient physical therapy 2 to 3 times a week. It is important that you have made transportation arrangements beforehand so you can get to your therapy sessions. Any equipment that is recommended for home can be obtained here at the hospital. The care manager will contact our in-house provider to let him know what equipment is needed and when you are being discharged. Our equipment provider will deliver the equipment directly to your room before going home. Another way of leaving the hospital is to go home with home health services. This may occur if you're not quite ready to attend outpatient physical therapy shortly after arriving home. The first home health professional that will come to your house is the home health physical therapist. They will come to your home 3 times a week. The other home health professional that may come is a registered nurse. The nurse would come based upon any medical needs you have that need to be monitored while you are considered homebound. Home therapy would last approximately 7 to 10 days. When you are finished with home health, outpatient physical therapy will be set up at that time. Again, it is important to have someone designated to drive you to your therapy sessions. Any equipment needed for home will be taken care of by our in-house provider before leaving the hospital. Whether you go straight to outpatient physical therapy or you go home with home health services, you will be responsible to perform your basic physical therapy exercises every day, 3 times a day. These exercises are essential to a successful outcome after knee or hip replacement surgery. Also, it is important to have someone with you at home until you are safely navigating in your home. In rare instances, it may be necessary to be discharged to a skilled nursing facility, but this would occur only if certain criteria are met. Our care manager will help you make the needed arrangements if this is necessary. Now I will demonstrate our pre-strengthening program. This is a sheet of exercises to perform before your surgery. This sheet was given to you in the surgeon's office. We find the stronger you come in for surgery, the better your recovery will go. Please do these exercises to your tolerance and perform them in the bed. Complete 10 repetitions of each exercise 3 times a day. It is best if you can perform these on both legs, as you will be relying on the opposite leg as you recover. The first exercise is called ankle pumps. Basically, you're just pumping your ankles up and down. We will also be asking you to do this after surgery to prevent clots. Quadricep sets. So when you're laying in the bed, you basically are just pushing your knees into the bed. That tightens the quadricep muscles here. Hold it for 3 to 5 seconds and release. The next exercise is gluteal sets, where you're squeezing your buttocks muscles together, again holding for 3 to 5 seconds and letting go. The next exercise is hip abduction, adduction with extended knee. So when you're laying in the bed, you basically are just pulling your leg out to the side and coming back in. Straight leg raise. We want you to lay on your back again and bend the opposite knee so you don't strain your back. So you basically are just raising your leg up straight as high as you can get it. The next exercise is short arc quads. If you could make a bolster out of a couple pillows tied together with some tape, that would be great. You place that underneath your knee and you basically are just pulling your legs up. Again, it gets those quadricep muscles strengthened. The next 2 exercises are upper extremity exercises, and you're probably asking, why am I doing upper extremity exercises when I'm having surgery on my leg? The reason is you're going to be relying on that upper body strength as you get up and down out of bed, as you're using your walker. So it's important that you have your upper body strengthened. The first one is a chair push-up. So you sit in a chair similar to what I'm sitting in right now, chair with arms, without wheels. You basically are just pushing yourself up and lowering yourself down. Pushing up and lowering down. That really strengthens your tricep muscles. The last exercise is elbow weights. So you can use a soup can, a water bottle, anything that weighs around 1 to 2 pounds. And you basically put that in your hand and you're going back like this and up like this. Again, it really gets that tricep muscle strengthened. So those are the pre-surgery strengthening program. After surgery, it's a very similar program, only there's a couple additional exercises added to it. We really can tell a difference in the patients that do these beforehand. Again, the stronger you are coming in, the better your recovery is going to go. I am now going to discuss nursing care you will receive from admission to discharge. The orthopedic team at St. Luke's strives for quality and excellence in all aspects of patient care. This standard is reflected in the way we treat and care for our patients through our high patient satisfaction scores and our lower complication and readmission rates. Division 8600 is the orthopedic division at the hospital. The night before surgery, please follow your surgeon's instructions for pre-op bathing that night and the morning of surgery. Please sleep on clean sheets and in clean pajamas. Do not use any hair products, lotions, deodorants, or makeup beforehand. On the morning of surgery, please check in at the same-day surgery registration located on the 3rd floor, which is the main floor of the hospital, across from the gift shop. You are welcome to bring comfortable clothes with you to the hospital to wear after your surgery if you so desire. If you have sleep apnea, please bring all your home equipment with you. After checking in at the same-day surgery desk, you'll be put in a room. Your family can be in the room with you. You will be assessed by a nurse at this time. If extra lab work is needed, it will be drawn then. Your vital signs will be taken, and then you will be asked to change into a hospital gown. Once you are done in the same-day surgery area, you will move on to the holding area. Your family will return to the waiting room. In the holding area, you will be assessed by anesthesia. You can discuss anesthesia options at that time. Most of our patients have general anesthesia with their joint replacement surgery, but I am seeing a trend for more and more patients opting for a spinal anesthetic. So you'll discuss this with your surgeon and the anesthesiologist. In the holding areas where your IV will be started and your leg will be shaved and prepped. We use best practice here at St. Luke's called timeout, where everyone in the room stops and the surgeon actually puts his initials on the surgery site so that surgery is done on the correct limb. Once you're done in the holding area, you move on to the operating room. It's very cold in the OR, lots of equipment on the tables, people in gowns, masks, and gloves. Anesthesia will continue your medication. Actual orthopedic surgery takes approximately an hour and a half up to 2 hours. So we say it's about 3 to 4 hours from the time you come into same-day surgery, move on to the holding area, then move on to the operating room and have your surgery. All that together is about 3 to 4 hours. So once the surgeon has completed the operation, he will do one of two things. He will either go out to the same-day surgery waiting room to give the family a verbal update on how surgery went, or he will call the family on the telephone in the same-day surgery waiting room to give them that update. Once the family members have received the update from the surgeon, then the same-day surgery secretary will give the family members a white slip of paper with a room number on the 8th floor that their loved ones will be going to. So your family is more than welcome to come up to the orthopedic floor at that time. They can stay in your room, watch TV. But because you're going to be in recovery at least an hour, maybe longer, that's usually a good time for your family to go get something to eat. Once you're done in the operating room, you move on to the post-anesthesia care unit, or the PACU, or recovery room, whichever you want to call it. You're brought to recovery in your hospital bed. You will have IV fluids infusing. You may or may not have oxygen on. It will just depend on your needs. They'll be putting lots of warm blankets on you, which is a real comfort as you're cold coming from the OR. They'll give you pain medication if needed, and of course they're going to be monitoring your vital signs very closely. So you'll have the blood pressure cuff on your arm and a sensor on your finger measuring your blood oxygenation and carbon dioxide levels. If you're not experiencing any nausea issues in the recovery room, they probably will offer you ice chips down there. If not, we'll offer them to you up on the floor. As I said, you're in recovery at least an hour, maybe a little bit longer, but once you're done in recovery, then you're admitted to Division 8600. Again, you're brought to your room from recovery in your bed. Usual length of stay is 1 to 3 days, and that does include your surgery days, so we don't get to see you for very long at all. As I said, you may or may not be on oxygen. You will have IV fluids infusing. You can begin to drink fluids and have ice chips. As I mentioned already, you probably will have ice chips offered to you in the recovery room. I highly recommend that you try some clear liquids at first, because your surgeon will have you on a diet the day of surgery. You don't want to get sick on a full stomach of food. So just try water, juice, coffee, soda, tea, Jello broth, whatever sounds good to you before advancing your diet. We do have room service here at St. Luke's, which is nice. You get to order what you want rather than receive the standard tray that everybody else in the hospital received, and that's not what you wanted to eat. So we'll give you a room service menu. On the front, it will say dial extension 4400 from your room phone. We'll show you that room phone, how to use it, and dial that extension, give your name, and it takes about 30 to 45 minutes for it to come up once you place your order. As I said, you may or may not be on oxygen. It's just usually on the first night after surgery. We try to remove it the first day after surgery. The nurses will encourage you to turn, cough, and deep breathe. This promotes lung expansion and helps to prevent pneumonia after surgery. 3 things we really try to avoid: infection, pneumonia, and blood clots. So if we see that you're not taking those deep breaths like we would like to see, we may bring in a device called an incentive spirometer. It's a great tool to reinflate your lungs, and we would teach you how to use that. As I said, you'll have IV fluids for the first night. You will receive an IV antibiotic 30 to 60 minutes before you go into surgery, and then depending on the type of antibiotic ordered, you'll get several doses in the 24 hours after surgery to prevent infection. So we usually leave the IV fluids running until the IV antibiotics are completed, And then at that point, if you're not experiencing any low blood pressure issues or nausea issues, we would stop the IV fluids. We would still leave the little plastic IV catheter in place in your vein if we were to need to give you blood or nausea medication the next day. Then we wouldn't have to stick you to start another IV. And then we flush that plug once a shift with some normal saline to keep the line open. On the slide, you see the pumps that we use up on the orthopedic floor for safety reasons, and they are very sensitive. So if your IV pump is beeping, please put your call light on to alert the nurse we need to come take a look at that IV. Pain management. Pain is one of the biggest concerns for patients following total joint surgery. Pain control is very individualized. The nurses and surgeons will work closely with you to identify a pain control regimen that keeps your pain at a tolerable level for you. Note, we said tolerable. We didn't say pain-free. There is no way you can have orthopedic surgery and not have pain. The goal is to control that pain. So we have a whole pain protocol that we work from. So in addition to the narcotic pain medicines, we also have different adjunctive medications that we can add to get your pain at a tolerable level for you. You will discuss your pain frequently with your nurse. You're going to be asked your pain score number frequently to help us identify how severe your pain is and if the pain medicine is working to control your pain. Tracking pain medicine. Pain medicine is PRN, which means as needed. You should ask for your pain medicine when you are ready to take it, and the doctors typically order your pain meds every 3 to 4 hours. The nurses will use the whiteboard in your room to help you remember when to ask for your pain medication. Cold therapy. It's an effective method of pain control when used in combination with medications. It helps with pain relief by reducing inflammation. So for the knee patients, your surgeon may order the polar ice machine. It's a container we fill with ice and water, plug in an electrical adapter, and then we put the pad over your knee incision, and then it circulates cold water over the knee. For the hip patients, we're more than willing to make ice packs up on the floor, but it is kind of an awkward place to have an ice pack. Side effects of pain medication, the balancing act. All narcotics are constipating no matter what form they're in. So we will automatically put you on an ortho bowel routine. We're going to give you Marilax powder laxative at 9 in the morning in either juice or water, and then we'll give you Senecot stool softener at 9 o'clock at night. If after a day or so you haven't had a bowel movement, we'll probably offer you milk of magnesia, Dulcolax tabs, or a Dulcolax suppository. We just want to make sure that things are working before you leave us. What we don't want happening is that you leave the hospital and you're coming back a week later through our ER doubled over in pain because you are all bound up and can't have a bowel movement. Not a laughing matter at all. And I'm not trying to frighten you. I'm trying to get you to be proactive and understand the importance. As long as you're on the narcotic pain medicine, you need to keep up some bowel routine. You don't have to do what we do here at the hospital. There's a myriad of over-the-counter products to help you with that issue. It truly is a balancing act in those first couple weeks. And also remember to be drinking adequate amounts of fluid, especially water, because that will help with the constipation issue as well. Home medications. Same-day surgery will contact you about a week prior to your surgery. At this time, you will need to provide a list of all the medications you are currently taking, both prescription and over-the-counter medications. The accuracy of this list is extremely important, so carefully read from the pill bottles. We really do try to stick to your home medication schedule, so just be very specific when giving that information. So what will happen is the same-day surgery secretary will compile a list in the computer of each medication with the dose and the time you take them with a yes or no box next to each medication. Once the surgeon has completed the operation, he will go down that list, click on the things he wants you to continue, click on the things he does not want you to continue. Most of the time, standard medications are reordered after surgery. We ask that you stop all aspirin, Plavix, and NSAIDs. When I talk about NSAIDs, I'm talking about non-steroidal anti-inflammatory drugs. This would be ibuprofen, Motrin, and Advil are the brand names for that, or naproxen, Aleve is the brand name for that, and Celebrex falls under that category as well as other prescription strength NSAIDs like diclofenac or Mobic. You need to stop these for about 1 to 2 weeks prior to surgery or as instructed by your surgeon. The reason why you need to discontinue these is because all these medications tend to increase your bleeding times. So we don't want you coming in as a bleeding risk having surgery. Most of the time it's probably only 4 to 5 days that you need to be off of them, so just follow your surgeon's specific instructions. You do not need to bring your home medications to the hospital, with the exception of some multi-dose medications like inhalers, nasal sprays, eye drops, and some injectable medications used to treat type 2 diabetes. And the same-day surgery nurse will advise you if you have one of these multi-dose medications that you need to bring to the hospital. You will not be eating or drinking after midnight the night before surgery. And if there are certain medications they may want you to take the morning of surgery, you would take those with just a small sip of water. Most of the time you're not taking anything, but there are certain cardiac or blood pressure medications that they may want you to take the morning of surgery. Blood clot prevention. Blood clots can be a complication of total joint replacement surgery, so there's multiple methods utilized to prevent clots. Everyone will be on a blood thinning medication for approximately 4 to 6 weeks after surgery. Recent studies have shown that a 325 milligram aspirin twice a day can be as effective as Coumadin, but it will be up to your surgeon as to what medication he chooses for you. If Coumadin is chosen for you, it does take 2 days for Coumadin to become therapeutic in your blood. So it's possible while you're here, in addition to the Coumadin tablets, you might also get an injection of a medication called Orixtra or Lovenox. These are low molecular weight heparins, another fancy term for a blood thinner. As I said, they are in injectable form. It's a tiny little needle we inject into the fatty tissues of your abdomen until that Coumadin is becoming therapeutic, but we're only going to send you home on the Coumadin tablets. If you are on one of the newer generation blood thinners like Eliquis, Pradaxa, or Xarelto, then your surgeon will work with the doctor, most likely a cardiologist, that puts you on that medication to get you to the appropriate dose the evening of surgery and for going home. TED hose and calf pumps also help prevent clots. TED hose are the white compression hose that help with circulation and keep swelling down. Not all the surgeons are continuing to use them, but if yours does, they will be put on while you're under anesthesia. You'll wear them here in the hospital, and then we'll give you instructions on how long you need to wear them at home. Calf pumps are Velcro wraps that will be around your calves hooked up to a pump that will alternately squeeze your calves to keep your blood flowing. We leave those on you for 18 hours a day. Some of the surgeons will choose to send their patients home with a smaller home version of the calf pumps, and you wear those for about 2 weeks, and we give you a box to mail back the equipment to the company. Early mobility is another way of preventing clots. That's the reason we're getting you up the day of surgery, because studies have shown us the quicker we get you up, the less chance of complications occurring in your recovery, one of which can be a blood clot. It's really important that you follow all of your doctor's instructions for blood clot prevention. Postoperative anemia. Anemia is common after total joint replacement surgery, so we monitor your labs daily. That would be your hemoglobin and hematocrit labs. Some physicians will recommend taking iron pills before and after surgery to help with the anemia. Iron pills are a great economical supplement to help rebuild your blood counts. They can cause nausea, so we give our iron pills with food. They also can cause diarrhea or constipation, and they will turn your stools very dark. That's very normal, but again, they're a great economical supplement to rebuild your blood counts. Some patients may require a blood transfusion. I would not say the majority of patients are transfused, but if your counts drop that low, it's really going to be important that we address that issue, as you will be very fatigued. It will be very hard for you to do your therapy, so we would address that issue while you're here. But again, I would not say the majority of patients have a blood transfusion. Surgical drains. You may or may not have a drain. The drains are removed 1 to 2 days after surgery, and it's the Hemovac drain. It's a white round plastic disc that has 3 metal springs that expands as it fills. And then we empty it once a shift and recompress, and it just has a little clip we clip to your gown. You take it with you. Either your surgeon's going to remove the drain or your orthopedic nurse will remove the drain. It does sting for about 15 seconds when we take the drain out, and don't be surprised if you see a little bit of bloody drainage on the dressing after we take the drain out. Foley catheters. Not all surgeons utilize them. If it is part of your surgeon's surgical protocol, it will be placed while you're in surgery and would stay in place for 1 to 2 days after surgery. If your surgeon does not have that as part of his routine surgical protocol, and anytime you're putting a tube in the body, that's another chance for infection. So we would monitor you up on the orthopedic floor for 6 to 8 hours after surgery. Hopefully you can urinate on your own in that time frame. We always have an order. We can get you up to the bedside commode with assistance. So just let us know if that would help you. We try everything we can to get you to go on your own. If you are not able to urinate after 6 to 8 hours, and sometimes that happens as a side effect of anesthesia, that bladder muscle just hasn't awakened yet. So we would need to bring in our bladder scanner, put a little ultrasound gel over your bladder area to scan you to see how full you are, because we can't ignore that you're not urinating. And then if we need to, we would place a Foley catheter up on the orthopedic floor that night, but it would only stay in place until the next morning. The continuous passive motion machine, or the CPM machine, used only after total knee surgery. Not all the surgeons use this machine. Studies have been done that show 6 months out you can't tell who has used one and who hasn't. It's passive range of motion, so it's not going to strengthen the muscles around your joint, but a lot of patients say the CPM helps to relieve some stiffness. So if your surgeon does use it, it's either going to be started in the recovery room or it will be started early in the morning of post-op day 1. If it is started on the day of surgery, we leave you in it as much as you can tolerate it. But because you're laying flat on your back when you're using the machine, at some point you need to get off your back, or especially when you need to come up to eat. Then the next morning when the techs come in early to draw your blood, they'll put you on the machine so that by breakfast time you already have a 2 to 3 hour time window done on the machine. You can sleep with it running. And then it will be up to you when you want to do the rest of your time. They will want you to use it for a total of 6 hours a day. We increase it by 10 degrees daily to a goal of 90 degrees of flexion. We actually try to have all of our knee replacement patients at 90 degrees of flexion by the time they leave us, whether you use the CPM machine or you don't. 90 degrees of flexion is what you need to go up a step. Extension is as important as flexion. Extension is with the leg out straight, so we work on that while you're in the bed. We do not place a pillow underneath your knees, and it's not because we're trying to be mean. The reason is if you leave your knee in that small crook for 8 to 10 hours, when they come in the next morning to straighten you out, it's very uncomfortable. Now, I'm not saying you can't turn on your side. Normally, when you turn on your side, you can't avoid bending your knee. We just don't want you staying in that position for 8 to 10 hours. And then we work on the flexion with the knee bent while you're sitting up in the chair. If the CPM is ordered for home use, that would be an equipment rental that our care manager would help set up and have it sent to your home. For the total hip patients, there are different surgical approaches for hip replacement surgery. Depending on your surgeon's approach, you may receive instructions to follow hip precautions after surgery. If these precautions are ordered, these will be taught and reviewed after surgery. You can certainly contact your surgeon's office with any questions. Activity expectations: increase your activity daily. Sit in the chair for all meals. Change your position every 2 hours. Please always have a staff member assisting you when moving from one place to another. We really want you to be calling us because we don't want you to fall while you're here, so please put your call light on when you're moving around in your room. We always use a walker and a gait belt at all times when out of bed. You will complete your exercises 3 times a day, 2 times with physical therapy, and once on your own. You will go down to our satellite gym to practice stair practice. So they try to simulate what you have at home, so you will practice that there. For the future, antibiotics will be needed prior to dental procedures, including dental cleanings, and prior to any surgical procedures to avoid infections in the new joint. The reason why we say even with a dental cleaning is because when they clean your teeth, that releases plaque. Plaque has bacteria in it. You don't want that bacteria getting in your bloodstream and finding your new hip or your new knee. It's an absolute nightmare to recover from a joint replacement prosthesis infection. And again, I'm not trying to frighten you. I'm trying to get you to be proactive and follow these guidelines. I've been told that when you have your teeth clean, when you set up your first appointment, which is probably going to be several months after surgery, call your surgeon's office. They will prescribe the antibiotic they want you to take. With a cleaning, it's probably just 1 or 2 doses of antibiotics. Then you can take that information to the dentist, and then he will have that on file for the future. If you're having another surgical procedure, chances are they'll protect you with an IV antibiotic before your surgery. New knee and hip implants will trigger metal detectors, which may require a manual search, so plan for extra time when traveling. I think the newer scanners are a little bit more friendly, but it depends on what screener you get at the airport, so it's always good to plan extra time when traveling. This concludes the Stride to Success program. Thank you for taking the time to view this video. If you have any questions, please feel free to contact your surgeon's office or the orthopedic division. We wish you the very best with your upcoming joint replacement surgery and recovery as you stride to success.